to this Urbe Group podcast, produced by our Medical Insight Studio. In today's episode, our clinical application manager, Dr. Niklas Froemmel, is talking with Dr. Lauren Troy from Royal Prince Alfred Hospital, Sydney, and Professor Venerino Poletti from Morgagni Hospital Forli in Italy. Today's episode is about the latest guideline update on the role of transbronchial cryobiopsy in patients with idiopathic pulmonary fibrosis. Our experts discuss the data that has paved the way towards this update. They highlight perspectives and trends identified in this new technique, including the Frostbite 1 study on the safety of the novel through the sheath cryobiopsy with the 1.1 millimeter cryoprobe.
Since the last guideline update in 2018, quite some time has passed. Maybe you can give us a bit of a wrap-up on the cold ice trial, which you conducted and which was decisive in the process that led to the current guideline update.
Thank you. Yes, it gives me pleasure to discuss this study. It was a multi-centre study that we conducted in Australia in between 2015 and 2019. And the impetus for the cold ice study was really the increasing usage of cryobiopsy across many centres in Europe and other centres, not as many in North America at that point, but increasing interest, certainly from a research and clinical perspective. And so we felt that we were well placed to address the question of how accurate the cryobiopsy was in comparison to the accepted gold standard surgical lung biopsy for interstitial lung disease diagnosis for those patients who needed tissue sampling. And we really felt that this was an important question to address. One, because of the risks around surgical biopsy in a fairly vulnerable patient population. And two, because the cryobiopsy is very, very small compared to the surgical biopsy, and it's sampled from around the airways. It doesn't come from the same location as the surgical biopsy, which is taken thoracoscopically. So we wanted to understand what its performance characteristics were if we were going to start using this to make clinical decisions for these patients that we treat. And we did the cold ice study comparing the two by doing both diagnostic tests in every participant. We included 65 patients from different centres all around Australia, all with an unclassified diagnosis with they're just based upon their clinical data and their radiology. And they were all subjected to the two processes within the one anaesthetic. We then went and addressed the accuracy by looking at the histopathology diagnosis and then the ultimate consensus diagnosis at a multidisciplinary discussion. And we were very pleased to find that in this study, there was a very good agreement between the two sorts of biopsy, both looking under the microscope from the pathology point of view and within the consensus multidisciplinary discussion for the final diagnosis. We ultimately found an agreement of 77% at the multidisciplinary diagnosis. And in particular, the people who had a high diagnostic confidence, so those where the panel felt that it was a very good, strong diagnosis, that the agreement was 95%. So really this study highlighted just how accurate the cryobiopsy was in relation to the much larger but more risky surgical lung biopsy for ILD.
Professor Poletti, you for sure know the cold ice trial and you know very well about the literature that has been published ever since. What's your thoughts on the impact of cold ice and the data that followed after it?
The cold ice study was a pivotal study because it compared cryobiopsy and surgical biopsy in the same patients. But we have a few comments to add. First of all, surgical lung biopsy is not a gold standard. The multidisciplinary discussion remains the gold standard. Even better, this multidisciplinary discussion and the discussion with the patient is even better. We have few studies. One is the CHILL study published in Respiration. They compared regular transbronchial biopsy, cryobiopsy, and surgical lung biopsy in the same patient, and they reported a good agreement between surgical lung biopsy and cryobiopsy. But I think we have more important study. One, the problem is how accurate is the diagnosis of UIP pattern at cryobiopsy. So we have another study deriving from the cold ice study, published again by the Australian group, Cooper and others in the Blue Journal this year. And when you have an UIP pattern according to the tabular criteria in cryobiopsy, these strongly predict UIP pattern in paired surgical lung biopsy with a node ratio of 23.4. And this is a very good point. And if we consider the other way around, what is the impact of UIP pattern in cryobiopsy? We have the study by my group, Tomasetti and others in Lancet Respiratory Medicine 2 years ago. And when we have UIP pattern in cryobiopsy, the clinical trajectory is completely different compared to the patient who do not have this pattern in cryobiopsy. So this is an important point. When you detect or you are able to recognize UIP pattern in cryobiopsy, the role of surgical lung biopsy decreases significantly.
Very important point that you mention, and that leads me to the actual changes in the present joint recommendations of ERS, ATS, and JRS. Dr. Troy, there is a conditional recommendation now for cryobiopsy in patients with a suspicion of an idiopathic pulmonary fibrosis. In your eyes, what is the minimum standardization that a center should have to minimize the risks tied to transbronchial lung cryobiopsy and maximize the diagnostic yield at the same time?
Yeah, certainly we're at the nexus of a bit of a change here, because previous international guidelines did not recommend for or against the cryobiopsy due to, I feel probably there wasn't quite enough data to support it. But here we are now with this recommendation, and it's really important that people reading those guidelines in various centres around the world understand the subtext to this, and the decisions behind it really relate to the competency of the centre and the absolute critical importance of good patient selection. And that goes back to Venerino's earlier point about the discussion with the patient. So having a very well-informed discussion with the patient about their wishes is the starting point. But making sure that they are appropriate to have any sort of invasive procedure is really key to minimise risk. We really want to make sure, firstly, that this patient really does need a biopsy, that they don't have other features that would otherwise lead you to a confident diagnosis, that they don't have unacceptable or uncontrollable bleeding risks. So that would be a situation where you couldn't correct their bleeding potential. That they don't have severe disease, because once people hit a certain point in their disease trajectory, a tissue diagnosis is not really going to alter outcomes. And so you want to really ensure that their physiology is not only really at a safe level to perform an invasive procedure, but you're getting the answer is actually going to make a difference to their outcomes. So you're not catching them at the end of their disease course. And that would include not including people with very severe pulmonary hypertension, or those who are in the middle of a severe acute exacerbation, who would be at risk of very adverse outcomes. And aside from those factors, it's really important that the centre, when starting out on this sort of procedure, has at least access to skilled diagnosticians or proceduralists from interventional pulmonology background, and that may be relying on some of the sort of apprentice-based training methods that have already permeated across the interventional pulmonology community around the world, where you are trained by others more experienced than you, and then you pass that learning on, or even accessing formal training programs where they're available. and ensuring that in your centre you have access to all of the important things like an intensive care unit or a thoracic surgeon or skilled anaesthetists and skilled nursing staff should you need those things. There are actual procedural components that really do mitigate risk, and I think we might talk to some of those a bit later in this discussion, where we talk about how to mitigate bleeding. And then once you've made sure that you have all of those components in place and you're able to set out in a safe way, then it comes down to a diagnostic outcome, and that relates to how well the pathologist is able to interpret the sample, how familiar they are with these sorts of small tissue samples, and also the access to a multidisciplinary discussion for the ultimate diagnosis is really key as well. So there's a number of moving parts. It's really important that centres consider all of those aspects if they are to embark on cryobiopsy as part of their diagnostic armamentarium.
Professor Poletti, you have mentioned this point earlier, so I want to dig a bit deeper here. Which impact does the timely diagnosis have in patients that are suspected to have an IPF?
We know that the early diagnosis is fundamental to reduce the declining of the disease, because we have a lot of solid data confirming that if you can intercept the disease in the early phase, you can reduce the declining and a prolonged life of the patient. So this is very important. But coming back to the ERS guidelines, I think this was a very strong effort. And actually, as Lorraine already underlined, we have a very important point. The first PICO question was if a patient is with an ILD in need of histology for an ultimate diagnosis eligible for surgical lung biopsy, can cryobiopsy be considered a valid substitute? And the answer was with a suggestion, not a strong recommendation, because it's difficult to obtain strong data, mainly when you are dealing with diagnostic tests. The second PICO question was when, and this is another important point, when you have a patient not eligible for surgical lung biopsy, in which histology could be a valid information for an ultimate diagnosis, can you consider cryobiopsy a good way to go? And the answer was yes, again with suggestion, non-recommendation, but it means that we are expanding the cohort of patients that can be submitted to biopsy. These are the main PICO question in the guidelines. We had other PICO question, and Lorraine already told about that. But these are the two main points. When we need histology, consider cryobiopsy first, mainly if you are in a center with skillness in ILD and interventional pulmonology. And it means that in that case, you have a diagnosis of an IPF in the early phase of the disease. And now we are dealing with so-called ILA, so patient with subclinical, mainly subclinical interstitial lung disease, in which a diagnosis could be very interesting from the clinical point of view. So I think that cryobiopsy will change, again, our approach to this patient, introducing the value of histology in a larger cohort of patients with the ILD and with a clinical suspicion of IPF.
Coming back to your comment on the skilled centers, which relates, of course, next to the valid diagnosis, also to the handling of complications. Dr. Troy, we know that 3 or more samples diagnostically yielded up to 85%, whereas less samples led to a diagnostic yield of 77% or less. Does this come at the costs of a higher complication rate in your eyes?
Potentially, but it's not there's no strong link between number of samples and risk, certainly not in the evidence that we've accrued so far. It really comes down to how experienced the proceduralist is, how well the patient has been selected, and how able you are to minimise any potential risk with every biopsy that you take. And so I think that every time we subject a patient to a transbronchial cryobiopsy or any invasive procedure, we're really doing a careful balance between risk and benefit at every moment. And certainly I think I'm keenly aware of that every time I do a cryobiopsy in patients who are already a little bit vulnerable and maybe at risk of adverse outcomes. So I think that every individual case carries a lot of minute-to-minute judgment, and it's one of those situations where the more experienced you are, the less likely you are to encounter those risks, so that the yield is really likely to be greater because you're able to take more samples with greater confidence. And so it's a fine balance. But yes, certainly some patients you might decide that you've taken enough, and the risks are likely to be too great to continue, but fortunately that's not a common scenario.
In case you encounter a bleeding, Dr. Troy, how would you typically handle that in your center?
We're really very cautious about bleeding. We fortunately haven't had any serious events with bleeding, but I'm very aware of places that have had serious outcomes because of bleeding. And so we would normally do a drill at the start of every case where we introduce a bronchial blocker into a proximal airway, and that would be done in a blinded fashion so that we can then assess what we would do in the worst case scenario should a patient have a life-threatening bleed where we lose all vision. So once we've done that blinded assessment, which we check with a flexible bronchoscope, and we know exactly how we're going to be able to occlude the airway, we then remove that larger bronchial blocker and we proceed with the case. And with every biopsy that we take, we do use rigid bronchoscopy at our centre, although I'm aware that's not always the case across other centres. We would introduce the smaller bronchial blocker down into the segmental airway that we are choosing to biopsy and ensure that it is held firmly in place, that there's no risk of slippage and that the occlusion with that balloon is complete, so that should there be bleeding, that the blood stays beyond the bronchial blocker and does not enter into proximal airways. And to ensure that you're going to have minimal bleeding into airways, we want to ensure that the person who's operating the balloon is experienced with that, just as experienced as the person who's doing the cryobiopsy itself. It's never a one-person job. We always have at least two people, frequently more, to ensure that we have all of the safety checks in place. And if there is bleeding that's not controlled with simple bronchial blockade, we sometimes would go to measures of using instilling agents onto the bleeding that might reduce the time. So, various centres will use various things, but we sometimes require topicalisation with adrenaline or tranexamic acid, and those are the sorts of measures we would take to minimise bleeding.
Professor Poletti, you are using rigid intubation as well, along with a bronchial blocker. Why would some authors not use a balloon blocker when they use rigid intubation, and what do you think about it personally?
I think that they are a little bit imprudent because, as Loren already underlined, the Fogarty balloon is the bronchial blocker you can use when you use rigid tube for intubation, can control very easily the bleeding. We have more than 2,000 cryobiopsy for ILD performed so far, and we didn't have any causality due to bleeding, and any patient who was admitted to ICU for major bleeding. You can use more than one bronchial blockers. We have 2 Fogarty balloon, 4 French and 6 French, and you can use both of them. And usually when we have biopsy in different lobes, we use 2 Fogarty balloons. So I think that according to the guidelines, ACCP guidelines and the European statement published in Respiration, bronchial blockers is a very prudent approach, a very prudent step in order to control bleeding. I have another comment. Now we have a prospective study using cone-beam CT, and in that case you can assess exactly where you are. So the problem with major bleeding is when you perform a biopsy too central. And in the future, I think that a good guide could be cone-beam CT or another guide system can help, or augmented fluoroscopy, for example, can help you to avoid this life-threatening complication, because if you stay very peripheral, the major bleeding is almost impossible.
Very valid point. So the bronchial blocker is, for the time being, something cost-effective that saves your day. Another maybe underestimated complication to the cryobiopsy, or to all potentially all sampling modalities in interstitial lung diseases, is the acute exacerbation, and from time to time its occurrence is associated with different sampling tools. Could you, Professor Poletti, again explain the mechanism behind an acute exacerbation?
Yeah, acute exacerbation was first observed after a surgical lung biopsy in the contralateral lung, not in the lung submitted to biopsy, but usually started in the contralateral lung, the ventilated lung during surgery. So the main hypothesis is that acute exacerbation observed in the majority of cases in patients with IPF happens because of high pressure oxygen in the airways, or as a secondary to barotrauma for high pressure ventilation. So an important point is to avoid oxygen, a lot of oxygen in the airways when you perform cryobiopsy. Actually, we have observed acute exacerbation in only 3 cases, and now I think the last one was controlled in our ward. So it's a very low rate of complication observed after cryobiopsy. One important point is to be very precise in order to exclude patients that have a rapid decline in the last months, for example, or they have ground glass opacities in CT scan that are anticipating the appearance of the clinical acute exacerbation, because acute exacerbation can happen per se in patient without any known trigger. So the first point is to avoid patients that could have an already existing acute exacerbation.
Dr. Troy, if we take a little glance into the future, I mean, we have come the way and see that cryobiopsy has such a strong position in the diagnostic algorithm for IPF now. How would you anticipate the adoption of cryobiopsy for other diffuse parenchymal lung diseases?
Well, I think we're already there in the future, because when we cryobiopsy patients, it's because we don't know that they have IPF. We don't, in fact, know what they have at all. We only find out once we've done the procedure. And so we are routinely sampling lots of patients with diffuse parenchymal lung disease of uncertain diagnosis. We sampling patients who ultimately will have the full spectrum of interstitial lung disease. And we have already, to a degree, evaluated the performance characteristics in these other diagnoses in cold ice. So we've looked at how it performs in hypersensitivity pneumonitis, non-specific interstitial pneumonia, in connective tissue disease-related ILD, and other less common interstitial lung diseases. But the data is limited within our population, and there are small case series in in other populations as well that speak to those specific diagnostic subgroups. So I think, though, we do expect that we'll be increasingly getting more information from small tissue samples, and indeed we'll be getting more information from even blood sampling and liquid biopsies, and we're moving it really to the era of precision medicine in interstitial lung disease, much the way we are already doing in lung cancer. I think the role of small tissue sampling is going to continue into the future for interstitial lung diseases as we get greater understanding of the pathobiology behind these diseases, and I think that we're already starting to see the synergy between, say, the genomic sequencing of the tissue and the macroscopic histopathology when we see the Invisia genomic sequencing platform and the data around that, and other platforms that are in development. So I think that there's a lot that we still, a lot of potential that we will still see with these samples that we take via cryobiopsy and other tissue sampling mechanisms.
Very interesting point, Professor Poletti. You made me aware of a study of cryobiopsy in patients with a rejection of their lung transplant allograft. Would you like to comment on that?
There is a paper by Lor and others, Barcelona group, that assessed the value of lung cryobiopsy in patients with lung allograft admitted to ICU. It's a very interesting paper because they compare 1.9 to 2.4 and 2 to regular forceps, and they concluded that cryobiopsy with 2.4 is better, and the diagnostic yield is significantly higher. The possibility to recognize histopathological feature related to graft reaction. So it is interesting because also it shows us that you can have cryobiopsy without fluoroscopy, for example, in patients with ICU. But there are other papers documenting the role of cryobiopsy in not IPF patients. First of all, in the majority of the case series, including our series published a few years ago with almost 700 cases, UIP pattern was observed in around 35% of the cases. So the majority were not UIP. There are also short series with bronchiolitis, with pleuroparenchymal fibrolastosis. And so I think that we have data, accumulating data on the role of cryobiopsy in non-UIP pattern. There is a second point to consider, that probably we could have material with smaller cryoprobes. Now we have in the market the 1.1, and there is a paper that is in publication assessing the safety of a sheath cryoprobe using the 1.1 from transbronchial biopsy, and they saw that you can have good samples without intubation if you use the 1.1 without a significant increase of complication, mainly major bleeding. This is a paper by Zeloni Yarmus group. And the third point is, as already Lorraine mentioned, the use of genomic classifier. Interestingly, with the genomic classifier, you need 3 to 5 regular transbronchial samples in order to have a diagnosis, a signal, UIP or not UIP. We don't have yet data on the role of cryobiopsy samples, because if you need less samples because they are larger, probably you can use cryobiopsy in order to confirm the molecular signal in favor of a UIP and to suggest an alternative diagnosis using histology. Because with Invisia system, it's difficult to obtain enough material for the genomic classifier analysis and for histopathology. So I think that, as mentioned, histology, thanks to this mini-invasive approach, will have a more important role in the diagnosis and classification of ILDs, and also in a major role in order to exploit all the sophisticated tests we can use with lung tissue, including molecular analysis.
A very interesting point that you mentioned also to the Frostbite 1 study you mentioned from the group of Lonnie Yarmus. It was done using the 1.1 millimeter cryoprobe along with the dedicated oversheath and showed the non-inferiority of safety to the forceps biopsy. So the safety was the primary outcome that this study was powered to. Are there any remarks you would still like to make in our discussion? Dr. Troy, maybe a final remark from you.
I think much has been said in this podcast and much has been said in the literature about the evolving role for cryobiopsy and tissue sampling. And as we continue to refine the process, thanks to new technology like the smaller probes, the disposable probes with the oversheath, and other applications for this technique, I think that we will potentially unlock many more exciting pathways for this diagnostic procedure. I am really excited to be part of this community and look forward to further studies and particularly further technologies that will come out of the clinical and research partnership in the field of ILD and other diffuse parenchymal lung diseases. So thank you for the invitation to be part of this.
Thank you, Dr. Troy. Professor Poletti, one final remark from your side, please.
I agree completely with Lorraine's comments. I think that in the future, we will have new guides in order to be very precise when you perform sampling of the lung. And we will have new technology in order to be more sophisticated compared to the hematoxylin eosin standard we have so far. So I think that immunohistochemistry and molecular biology technology will enter very, very, very soon in the field, and we will have new biological approaches, not only pathological diagnosis, thanks to lung tissue obtained with many invasive approaches. So I'm very confident on the future of cryobiopsy. Just the final comment, it is a technique that needs training. So don't start without any training, without any prudent approach, because otherwise you can just have problems and not good results.
Strongly concur.
Great open minds like Dr. Troy and Professor Poletti. Thanks everyone for listening, and stay tuned for more Medical Insights podcasts.
The cold ice study has led the way towards the Guideline update. Dr. Troy points out that it can provide an equal added value to the multidisciplinary discussion as compared to surgical lung biopsy. Nevertheless, transbronchial cryobiopsy for patients with IPF belongs in the hands of expert centers, which have a standardized protocol to mitigate risk tied to the procedure and deal with complications. In the future, cryobiopsy will most likely expand its role to other diffuse parenchymal lung diseases, as it delivers samples that allow for an analysis suitable to tailor the therapy more individually to each patient. With data from Frostbite 1, it was possible to investigate the safety of the novel through the sheath cryobiopsy transbronchially and obtain favorable results. Thank you, Dr. Troy and Professor Poletti, for sharing your experience, and Niklas for being here today. Stay tuned for our upcoming Medical Insights podcast, a podcast by the Urbe Group. To get further information and view our terms and conditions, please visit our website at www.urbe-med.com.